to 20% of women going through that menopause transition at any one point are considering leaving their jobs, which actually has a huge financial and economic impact. One thing we can be certain of is that all women will go through menopause at some stage of their life. It's an accepted school of thought that the perimenopausal symptoms creep in anywhere between about 7 years before the menopausal transition. And I guess the most common comment is, I just don't feel like myself. I'm more irritable. I go from 0 to 100 in a really short space of time. I'm starting to get that early morning, 3, 4 a.m. wake up. All my joints are aching. I'm tired all the time. And that tends to be the first herald that I see. I can't tell you that how many times I've had ladies sit in my consulting room and literally, I have a box of tissues that I always have handy because I know inevitably there's going to be tears. And some of those tears, I think, are around people breathing a sigh of relief that they're actually getting all of these worries off their chest and there's someone who'll listen that they can talk to. And I think some of it is also the frustration that they've had pent up and they've been feeling for the last, sometimes 5 years, about how dire they perceive their life and their current situation to be. I'm not sleeping. I don't like my other half. My kids annoy me. I'm hot flushing all the time. I can't stop crying. Some women really struggle, but they just, for whatever reason, because it's ingrained in us as females, they just struggle and they plod on and they think it's their lot in life and they just put up with it.
What do we do to get more information out there, and are we paying enough attention to it? I know you're busy. Can we talk menopause?
Yeah, of course we can.
So tell me about, what is menopause? Maybe we just real basics.
Yeah, sure. So one thing we can be certain of is that all women will go through menopause at some stage of their life. It's generally, the consensus is that anywhere between 45 and 55 years of age is a normal transition through to menopause, with the average age in Australia being 51. And menopause, once you've been through menopause, that's actually defined as 12 months without a period. So if you're less than that 12 months without a period, you're still described as being in the perimenopausal phase. But once you've had that 12 months, no period, no bleeding, you're now postmenopausal. So you've been through menopause. So I guess that's the traditional definition. Where the waters get a little bit muddied is that in that lead up to the menopausal transition, many women experience symptoms. So we know that around about 20% of women transitioning through menopause and through that perimenopausal phase will have quite severe symptoms. Then we know 20% have very mild symptoms, and that leaves the remaining 60% of sort of moderate symptoms. So not insignificant in terms of impact on women's lives. And I think, women notoriously have been quite good at just putting up with feeling uncomfortable or maybe not feeling quite themselves and just getting on with things. And I think that's all starting to change. And social media has a little bit to do with that. It's both a blessing and a curse in many ways. So there's more information out there. Women have more information around menopause and the menopausal transition and how that might look. There is quite a bit of misinformation, though, that's still spread over the internet by various groups. And, we expect that. We know that social media isn't edited for its evidence-based guidance. And that's where if you go and have a talk to someone with that evidence-based knowledge, you can perhaps get a little bit more realistic information, and then you can base your ongoing decisions on that information. So there has been a few studies overseas that have looked at women and the effects of the menopausal transition on their utility in the workforce, and up to 20% of women going through that menopause transition at any one point are considering leaving their jobs, which actually has a huge financial and economic impact. And that's something that often we don't think about when we talk about health and women's health in particular, but that's a huge chunk of the workforce. So that's one aspect to think about. And often the stress and the struggles of that are around the brain fog. So many women come to us talking about feeling really thick in the head. They can't, word finding difficulties, can't quite think about what they want to say, or walk into a room and forget why they were there and get quite frustrated with that. And that can be a bit multifactorial. We think there's a degree of hormonal fluctuation that's causing that, but there's also, we know that sleep disturbance becomes a bit more prominent through this transition. So it's a little bit of a chicken and egg scenario. Is the sleep disturbance causing the brain fog? It's probably contributing to the brain fog, or vice versa. But lots of impacting factors, lots of things that play into this upheaval, if you like. And one of the things I also say to or discuss with many women is the challenge that is often around. Many women going through menopause have early teenage children. So not only are you going through these physical challenges yourself, but you're also then having to parent teenage children, and there's quite a bit of stress around that often. So there's a lot happening in this life transition in those sort of 40s to mid 50s. Probably the other thing worth mentioning is it's generally accepted. It's an accepted school of thought that the perimenopausal symptoms creep in anywhere between about 7 years before the menopausal transition.
Wow, that's a long time.
That is a long time, absolutely. So, with that, bearing that in mind, if you think that 45 can be the time that you transition through menopause, really you can have some of these symptoms coming up in your late 30s. And certainly I have seen women that present to me with increased anxiety and some changes in their sleep that are sometimes started on some of the antidepressant medications. And I'm not saying that's right nor wrong, but if they are some of the symptoms that are creeping up around that sort of early 40s mark, this is one of the things that I always keep in the forefront of my mind. Is this the start of that perimenopausal transition? And should that be something that we consider in these women, so we don't just jump to one of the antidepressant medications? Could we give them a little bit of hormonal support and see if we can settle things down that way? So very interesting.
Isn't it? Wow, that's like opening up a big cracker.
Pandora's box.
There, just to say, well, are we paying enough attention to it to maybe understand what it is, and instead of saying, you might be depressed, take this medication. And I guess a lot of jumping to conclusions that are possible here.
Yeah, and I guess that's where that comment that I made before about social media being a double-edged sword, I guess that's where there is a benefit to all this information that's available on social media, because I think for the first time ever, women are starting to, we're really good generally at trying to find out about our health. And I think with more being available online, I think women are starting to investigate and research and starting to think, hang on a second, could this be perimenopause? And so they're coming and asking those questions, which is fantastic, because that's the point that we can jump in and say, well, yes, actually, it could be, and let's have a look at all your other symptoms. Probably the other thing to mention, Hannah, which I find fascinating, is estrogen's effect systemically throughout the body. Because we used to always think that it was predominantly a sex steroid and responsible for reproduction and ovulation. But we actually know now that it is so much more. We know that there are receptors in the brain. We know that it can affect GABA, dopamine, and serotonin receptors in the brain, which is where we think we might be getting some of those mood fluctuations. We know there's receptors on the lining of blood vessels, and it interferes with or it influences a pathway which is involved with smooth muscle relaxation, so lowering of blood pressure and dilation of blood vessels. That's the nitric oxide pathway there. We know definitively that it acts on receptors in bone, because we know, in fact, the only thing that estrogen is indicated for currently from a primary prevention perspective is bone health. So we know up till the age of menopause, you have this beautiful little balance between bone buildup and bone breakdown. And once you transition through menopause, we start to have more bone breakdown, less buildup. And so that decline in bone density commences at that point. And estrogen can certainly hold that bone density where it is and prevent that decline, which is really, really important for some women, especially women with risk factors for low bone density. We know that estrogen receptors are within collagen and skin and tissue, and we see when they go transition through menopause, we start to get that slightly more increased skin laxity. And we know that there's more frozen shoulders, there's more greater trochanteric bursitis, lateral epicondylitis, so tennis elbow, all those things start to creep in, a few more musculoskeletal aches and pains.
Is that
and we all
related to collagen? Do you mind if I interrupt with a few
Yeah,
questions?
no, go for it.
There's about 50 million and going through my head right now.
Mm.
Those things, are they partly related to collagen?
Yes, yeah. And then some people ask me then about, so should I be supplementing with collagen? And I think the evidence is a little bit mixed around collagen supplements. And I think probably the other good thing to mention is there's quite poor longitudinal, good evidence-based research done on women. The vast majority of research that's been done to date is on men. And women so I guess to take one step back in 2002, 2003, the Women's Health Institute study was released out of the UK. And it was one of the largest studies ever done on women. More than 1 million women participated, and it was stopped early because of what was perceived to be an increased breast cancer risk. Now, they've done subsequent statistical analysis and they've realised that actually that data was incorrectly released and it hadn't been properly analysed before it was released. But I think it did a huge disservice to quite a number of women over the next decade that dropped their HRT on a dime and really stopped taking it. We know now actually that's not a statistically significant increase, what was found. And the study in some ways was quite flawed in that the average age of women that were recruited into that study was 63. So more than 10 years postmenopausal. And we know, and this is one thing that the study has told us, which is quite interesting, is if you delay your commencement of HRT until more than 10 years postmenopausal, you can increase risks. So you can increase cardiovascular risks and a few others. But so if you start it within that 10 years, you're better off than the data that we've got available tells us that you're probably better off than if you start it after 10 years postmenopausal. That's not to say you can't start it more than 10 years postmenopausally, but it just needs quite a detailed discussion around the risks and some investigation into possible underlying cardiovascular risks, which can be exacerbated once you start that estrogen 10 years post. So never say never. I'm not saying you can't start at more than 10 years, but the general consensus in the literature is that if you can, you start it before you're more than 10 years postmenopausal.
Yeah. The logic makes sense, but it sounds like it's something you need a discussion about rather than just jumping to conclusions with any of this.
And for some people, hormone replacement therapy is not right for them. So whenever we as clinicians think about menopause, we always think about 3 broad groups. We think about the hormone replacement for menopause therapy. So that's one option, not right for everyone. And there's a bit of a tailored approach for each person. Then we think about the non-hormonal pharmacological treatments. And then we think about diet and lifestyle. And I like to think of the diet and lifestyle as the fundamental, the foundation of the pyramid. So, if we can get things right, like exercise, we know especially early morning exercise when that cortisol is slightly at its highest, we know that there's really good benefits for cognition and dementia for people that exercise regularly. We know if people add in good weight-bearing exercise, there's amazing benefits for bone. So, exercise sits in that beautiful little base of the pyramid. Diet and lifestyle in terms of foods we eat, so avoiding too much alcohol consumption. And we know the British Menopause Society talks a bit about, they have a beautiful pictogram on their website actually about the increased risk of drinking 2 standard drinks of alcohol per day. And that increases your risk of developing breast cancer more than taking worst case HRT. Their data was based on that Women's Health Institute trial. So it's quite interesting when you have a look at the influence that something like weight gain has on breast cancer risk, smoking has on breast cancer risk, alcohol has on breast cancer risk, and exercise actually reduces breast cancer risk. So it's something that I like to talk to all my women about in terms of, these are the fundamentals. This is the do not avoid category, and then the others are little adjuncts on top. Yeah.
Can I ask you, and this is going back 5 steps because the conversation is quite rich and in depth.
Mm.
What are the symptoms of perimenopause? How would we know? Or how would we identify that maybe it's perimenopause?
There's a list of symptoms that are described by the Australasian Menopause Society, and those symptoms fall into a few categories. We've got the vasomotor symptoms, so things like hot flushes, sleeplessness, and then there's one other which I can't recall off the top of my head, apologies. And then there's the musculoskeletal symptoms. So there's a range of musculoskeletal, aches and pains. And then there are the mood symptoms, so things like increased irritability. And then we have the genitourinary symptoms, and we call that the genitourinary syndrome of menopause, and they're to do with, urinary urgency, uncomfortable intercourse, a dry vagina, that sort of thing. So what I have noticed with the women that I see is the ones that come in fairly early into their menopausal transition, so really early in that perimenopausal phase, often they present more with the musculoskeletal and the mood symptoms than they do with the traditional hot sweats that women, hot flashes, I think the Americans call them, that women traditionally associate with menopause. So that, in my experience, has crept in a little bit later on in the transition, where the earlier symptoms that women come to me with is, and I guess the most common comment is, I just don't feel like myself. I'm more irritable. I go from 0 to 100 in a really short space of time. I'm starting to get that early morning, 3, 4 a.m. wake up. All my joints are aching. I'm tired all the time. And that tends to be the first herald that I see.
You do at that stage, if you do a consult with a woman and you assess this might be perimenopause, what would you offer?
Yeah, so, well, good question. So normally I don't, people like to talk about blood tests, and I think we've become a little bit hooked on, as a population, on wanting a test to prove a scenario. Perimenopause is quite interesting. We are guided and we base our decisions clinically on the symptoms that our patients present with. So we tend to run through this criteria, this cluster of symptoms, and if it's impacting a woman's life and they're experiencing enough of these symptoms, often we'll just do a trial of therapy if it's appropriate for them. Always got to stress, some women this is totally not appropriate for. And the type of therapy also depends on what the patient would like to do, what their symptoms predominantly are comprised of, what their past medical history is involved, and then what fits best within their ethos and their cultural beliefs as well. Because we often find that some women, especially some of my women from Asian backgrounds, it's almost a little bit of a rite of passage to go through the menopausal transition. And it is seen like that movement into that mature part of your womanly life. That's not the case with everyone. And some people say, and likewise, some people say to me, oh no, I don't want any hormones. What else can I do? And we have a talk about some of those other pharmacological options that are non-hormonally based, as well as that diet and lifestyle stuff, which can help. And then some women are really open to trying hormones. And for some of those women, if they don't have the risk factors that would concern me about starting those hormonal based medications, then we can absolutely give it a trial. Yeah.
So thank you for that. What are the potential consequences of not putting it on the table and trying to address the issue?
Well, I think there's a few answers in that question, Hannah, to be honest. I think as medical practitioners, our job, if I'm honest, is giving our patients as much information as we can, as much evidence-based information as we can, and then allowing our patients to make the decision that's right for them. I don't like a paternalistic approach to medicine. I like patients being able to take charge of their healthcare and decide what they would like to do. And I think ultimately that works best for patients anyway. That allows them to take ownership of their healthcare. So I think in terms of maintaining a really good patient-doctor relationship. I think it's important to give your patients as much information as they would like, and that they can deal with, and then they can make the decision that best fits with them. There are some scenarios where I may recommend the hormonal replacement more over other options, and some of those are around things like bone health that we touched on before. So, you know how before we were saying that estrogen for primary prevention of decline in bone strength. So, for example, if I had a patient that maybe had been slightly underweight as a younger woman, and her peak bone density was a bit lower, and we did an early bone density check on her, and she was shown to be osteopenic or have low bone density, then my recommendation to her would be more around, look, your bones, they're already low in terms of their density, so you're more at risk of a fracture. Why don't we consider estrogen hormone replacement based therapy in order to try and keep your bones as strong as we can for as long as we can, so that they last you well into your 70s, 80s, 90s. So where if I have a lady come to me that's had previous breast cancer, hormone replacement therapy is generally not, well, it isn't advised. So that the guideline is that we don't give women that have had a previous breast cancer hormone replacement therapy. And there's a bit of contentious debate around that. I know there are some practitioners that will. Again, requires a really, really long and quite detailed discussion about risks and benefits. But in those sorts of women, I tend to, my first port of call is those diet, lifestyle factors and non-hormonal treatments.
So you go from perimenopause, which would start even 7 years before the onset of full-on menopause. How long does menopause itself last? I imagine range, because it would be individual.
Yeah, so that menopausal transition by definition is the 12 months without a period. Then you're postmenopausal. But when you're postmenopausal, you can still be getting symptoms. So I have some ladies in their 70s that are still getting hot flushes. Wow. And they've tried to come off their hormone replacement therapy, and they still find that their hot flushes are quite debilitating. So I do have some ladies up in their 70s who will continue on their HRT. And then again, that comes down to that risk-benefit discussion with your patients. Just making sure that they're aware of the risk with, long-term use of HRT. And then obviously having that discussion around the benefits that they're getting, and therefore, what would you like to do? Bearing in mind these are the risks as we start to age, things change. The guideline used to be that by the age of 60, women would generally be stopped on their hormone replacement therapy. But that's changed. The International Menopause Society and the Australasian Menopause Society has taken away that time-based limit. And really now it's about having those discussions with your medical practitioner about the risk benefits and deciding whether or not the benefits outweigh the risks. And if they do, then there's quite a good case to continue if the patient wants. If not, then that's a shared care discussion about whether or not it should be stopped.
Yeah. So it's going to happen. If you're a woman, this is going to happen anyway, whether you like it. You have no control over it. And I don't hear it spoken about, well, rarely, up until we were having these discussions. It was never even spoken of, which astounds me for something. We talk about death because it's coming for all of us. Menopause is coming for women, but we don't think about it. What do we do to get more information out there? And I think there are two big questions for me. There's the education and information, so everybody knows, hey, this is going to happen. And then what do we do as a family to provide support, knowing that, hey, this is coming? And actually family discussion would probably be great. To say, well, some stage this is going to happen to me, and this is not what it might look like.
Yeah, and I guess that's different on that looks different for every family, and some families talk about these reproductive issues more openly than others.
Mm.
I certainly know I've tried to instill in my boys a bit of knowledge about girls and menstrual cycles, just so that there's a bit of an understanding about, you know, being a little bit kind and reasonable, and understanding that everyone's facing different challenges at different times, and being supportive to their peers in case, you know, they're struggling or going through a bit of a tough time. And certainly I think now that it's more out in the social media sphere, I think people are talking about it a bit more. I've seen quite a few. I like to keep my finger on the pulse as to what's happening on the social media side, because it always gives me an idea about how my patients, I think, are thinking and what they're going to come and ask me. And I have noticed of late there's been quite a few men who have been posting videos on, you know, Facebook and Instagram and TikTok and all the rest of it about their wives or partners going through this transition, and, you know, making sure that you're supporting them when they're a bit irrational, and you know, don't rise to the occasion. If they're snapping at you, just let it go. And I think that's all very helpful, to be honest. I think it's something also we need to start talking about a little bit more within. Well, I know it's happening within my friendship groups. I'm plumb in that age group. And certainly a lot of my friends are starting to talk about it and be a bit more open about the symptoms and how they're feeling. I guess the other thing is normalising the ability for women to go and seek help when they need it. You don't have to struggle in silence.
Is that normal?
Sorry, Hannah, say that again.
Is that not normal?
I think you know, I've heard of a few women that have been struggling, and they all say to me, oh, I just need to go and see someone about it, but I haven't had the time. And I think that's, again, a bit of an indictment on our really busy lives at the moment. I think everyone's running pedal to the metal and quite flat out. And I think notoriously women have been quite poor at prioritising themselves. We tend to put our families and our kids first, and we take the last step we're the last spot in the line. So often these things don't get dealt with for quite a period of time, until symptoms get so that, you know, really women are not coping and they feel like they're on a bit of a verge of a breakdown, and then they'll go and seek help. I can't tell you how many times I've had ladies sit in my consulting room, and literally I have a box of tissues that I always have handy, because I know inevitably there's going to be tears. And some of those tears, I think, are around people breathing a sigh of relief that they're actually getting all of these worries off their chest, and there's someone who'll listen that they can talk to. And I think some of it is also the frustration that they've had pent up and they've been feeling for the last, you know, sometimes 5 years, 5-6 years, about how dire they perceive their life and their current situation to be. You know, I'm not sleeping. I don't like my other half. My kids annoy me. I'm hot flushing all the time. I can't stop crying. Some women really struggle, but they just, for whatever reason, because it's ingrained in us as females, they just struggle and they plod on, and they think it's their lot in life, and they just put up with it. And that's where, you know, I'd encourage anyone who is feeling like that to definitely go and have a chat with their GP, have a talk. There's options. There's lots of options, and sometimes a problem shared is a problem halved. And sometimes there's many different avenues that you can approach these issues from.
Yeah. Wow. Sorry, I interrupted you, but I just found it astounding. In my head, this is total ignorance on my part. I imagine that women talk about their health with other women and their doctors like they do with relationships and many things. That's clearly the case.
Yeah, and look, I think some of them do, and I think we're better at it than men, to be honest. I think we seek more validation with our friendship groups than men do around this sort of thing. So I definitely think women do that better. I just think we prioritize ourselves often last. And so even though you may be having those discussions and think, oh, gee, I really need to go and speak to someone about this, you'll be the last cab in the rank. Yeah. So
what do you think we could be doing better? What would be helpful? What would you?
Yeah, I think, to be honest, we need to be, I've got to stop saying I think, to be honest, Hannah, if I say it a lot. I think we should be putting more of this menopausal management in the medical curriculum. We learn very little about it at medical school. Most of the GPs that work in this area, or GPs that work in the specialist menopause clinics, all have done extra learning and sought information and done their own research. So it hasn't really been a priority in the mainstream medical teaching today. I definitely think that's an avenue that can be done better. Certainly, we are trying to put more information out there. So I think that can definitely help. I think that's that potentially benefit of the social media side of things, where we're getting a little bit more of that information out and about on social media. That doesn't mean all of it has to be right. It just should be a really good impetus for people to seek more information, which is good. Yeah, and I think things like what you're doing with a podcast, I think that's a great idea. I think looking online and the online resources you can get as well. I would caution people to try and get good evidence-based online resources. So Jean Hale's website is a great one for women. If you have a health background, the Australasian Menopause Society is fantastic as well. There's some great government websites for things like bones. The Healthy Bones website is a wonderful resource for bones and information about diet and calcium and bones. So, and there's numerous podcasters around that do give some information out around menopause, and they're all really good avenues to pursue as well. So I think the more we just keep talking about it and keep the dialogue open, I think the better in the long run for many women.
Yeah, maybe a good conversation at home might not go astray.
Yeah, absolutely. And even, you know, with like I said, mention my boys, you know, it's really important to have an understanding that, hey, mum might be really irrational at the moment, but maybe she's struggling a bit, or maybe she's going through, you know, a bit of a challenging time. Maybe she's woken up a couple of times in the middle of the night, and that always makes your fuse a bit shorter. All those sorts of conversations, I think, are really helpful.
Yeah, fantastic. Thanks for your input. Where do people find you if they think, yeah, I should go and see someone, and they go, that's my person, Dr. Julia?
Yeah, look, well, they can absolutely find me, but in the broader sense, I would encourage people, if they want to come and speak to someone about menopause, if you log on to the Australasian Menopause Society, they have a list of menopause practitioners, and you can search by location. So I'm based up in Kalamunda and down in Vic Park, but if you Google the Australasian Menopause Society and practitioners, there's a whole list of people that work all round WA and Australia. You can pick the state and the location, and then you can find out who's closest to you. And all of those practitioners have done that extended learning in the menopause space. So good group of people to find.
Fantastic. Thanks. I know you're super busy, so thanks for taking a little bit of time from your schedule to talk about it.
No problems.
There's so much I could unpack, but I'm mindful of time, and I think that's probably just a good starter for people to think about.
Yeah, look, and I know I'm sorry to bombard you with so much information, because there's a lot there, but it is actually quite a fascinating life transition. So I'd encourage anyone that wants some more information to, you know, start some research.
Yeah, you know, if we had the time, there's so many interesting threads I really do want to talk about. Osteoporosis and hormones, and you know, it's all interrelated, isn't it? It's like a web.
Oh, it's absolutely fascinating. Yep.
All right. Thank you so much. Have a good
No problems, Hannah.